So good morning, everyone. I am so glad everyone is here. Looking forward to our talk today and spending the next 3 or so hours together. So this is Beyond Baby Blues, an in-depth look at reproductive mental health with myself, Dr. Armstrong, my colleagues, Dr. Hopkins, and Dr. Crall. To go over a few initial slides, there is minimal risk to attending this CE event. However, participants may experience some discomfort during the discussion of reproductive losses, suicidality, and issues that may arise when individuals experience anxiety or mood disorders during perinatal and postpartum time periods. We encourage you all to seek appropriate consultation and supervision whenever utilizing a new intervention. And all clinicians and providers are responsible for practicing within the bounds of their own clinical competence and following the ethical and legal guidelines for the states in which you practice. A few other notices. So there's one conflict of interest. Dr. Sheila Crowell is a co-owner of UCEBT and may benefit from any referrals to this practice, and we have no commercial support notices to disclose. With regard to AI, the only use of AI in this presentation was to help generate the title, but all other content was created by humans and human brains. Okay. So to provide a little bit of an overview of what our presentation will cover today, we have in our agenda here. Please put your questions in the Q&A so that way they are not lost among the chat, but the chat will be monitored throughout our talk today. So if you have comments, anything like that, you're welcome to put them in the chat, but please put questions in the Q&A so we make sure that we get to them as much as we can. Dr. Crowell, Dr. Hopkins, and myself have all completed a specialist certificate course in reproductive mental health. But for the purposes of our event today, we're really going to be focusing on perinatal mood and anxiety disorders, perinatal OCD, reproductive trauma and grief, perinatal rumination, and perinatal suicidality. However, please do keep us in mind for referrals or questions that may be more broadly within the scope of reproductive mental health. Okay. Before I begin this first section, I wanted to introduce myself briefly. I am a postdoctoral fellow and licensed clinical psychologist here at UCEBT. Throughout my graduate training and my clinical experience, I have developed a focus and a specialization in health psychology as a broad category, with more specific experience working with individuals with chronic pain, sleep issues and sleep disorders, gastrointestinal issues, and reproductive health issues. We're going to start off with a few definitions and important notes. The first note that I have is that each of these topics that we're going to cover today could be an entire presentation all on their own, so we may not be able to do as much depth as we would like for each of these topics, but we will do our best. During this presentation, we may use the terminology of women or mothers when referencing individuals who are born with a uterus and ovaries, or individuals who are pregnant and going through childbirth. But many individuals who are assigned female at birth may not identify as female, and I don't want to discount the experiences of those who may identify differently. Part of why we may use the terminology of women or mothers interchangeably is that the vast majority of research on these topics assumes that the individuals are female identifying and assumes that they are either heterosexual individuals or heterosexual couples. So for efficiency and to coincide with the research, we may use these labels interchangeably, but we wanted to make sure to acknowledge individuals who may identify differently, but have similar experiences to those with whom the research has been conducted. We also wanted to make sure we added this note in because a lot of the techniques that we'll be talking about today are good fits for these presentations, but it's important to include the terminology in the context of LGBTQ+ affirming care. The other definitions I wanted to go over are the definitions for perinatal and postpartum, because I think we hear these terms a lot, but wanted to kind of just clarify a little bit of the actual definitions. So the Merriam-Webster definition of perinatal is occurring in, concerned with, or being in the period around the time of birth. So perinatal can include before birth, the time around birth, but it does not include as much the time after birth. And the Merriam-Webster definition of postpartum is occurring in or being the period following childbirth. So essentially childbirth on. I also wanted to make sure to note the limited cultural representation that exists within the research and the literature on these topics. Research on pregnant individuals is already limited due to the protected nature of this population within research, and pregnant people of color often have higher rates of pregnancy-related mortality and barriers to access to care. And often this research uses self-report and retrospective data rather than conducting research in the moment due to the vulnerable status of pregnant individuals. And lastly, the criteria for premenstrual disorders, which we'll cover a bit, is still evolving. There's research that's ongoing and is gaining more insight into these different premenstrual disorders. So the criteria that I'll be discussing in this presentation is reflective of the current research and the current diagnostic criteria at this time, but essentially keep in mind it may change at some point in the future. I want to spend a little bit of time going over the biological changes and physical considerations for these time periods. The average age of menarche, which is the first period or the first menstruation, for individuals is about 12 years old, with a range from 9 years old to 15 years old. And the average age of menopause is 51 years old, ranging from the early 40s to the mid 50s. So menstruating individuals have around 40 years of experiencing cyclical hormone fluctuations. I won't be going into the changes that occur during perimenopause and menopause in this presentation, as it is more focused on premenstrual and perinatal disorders and implications, but there are a multitude of physical changes that occur during those biological transitions as well. So when an individual becomes pregnant, there are numerous physiological changes that occur. Everything from increased thyroid hormone production to increased cardiac output, even a change in the location of your diaphragm at rest, and the blood volume increases by about 1.5 liters. There's also widespread changes to our organ systems, including the cardiovascular, endocrine, respiratory, hematologic, gastrointestinal, and urinary systems. Pregnant individuals also develop an increased pain tolerance, higher skin temperature. They can develop acid reflux, increased melasma, more insulin sensitivity, and higher blood sugar levels. So there's widespread physical changes that occur when someone does become pregnant. And to offer a little bit more insight into the hormonal changes that occur during pregnancy, the pituitary gland itself enlarges by about 135% during pregnancy. And thyroid-stimulating hormones, estrogen, and progesterone, among many other hormones, increase in production during pregnancy. This increased hormone production can actually reduce the risk of autoimmune conditions for up to 5 years after pregnancy and can reduce the risk of relapses for autoimmune conditions like MS and psoriasis. So even though there is this massive increase in hormone productions, there is a protective aspect to it as well. And then after birth, there is a huge drop in estrogen and progesterone, which can contribute to mood and affective changes after birth. It's one of the theories that we'll go into related to postpartum depression, just this dramatic drop in estrogen, progesterone, and the thyroid hormones as well. I wanted to note as well with these physical considerations that there's a large evidence base on the increased risk for adverse obstetric and pregnancy outcomes for pregnant individuals who are experiencing mental health issues or mental illness. And that increased risk can include a risk for preterm birth, fetal growth impairment, and a risk for preeclampsia. So kind of the connection of our brain and our body comes even with these as well. We wanted to just kind of note those potential increased risks there. I also want to cover a few of the significant shifts that do occur during a menstruating individual's reproductive lifetime with regard to social changes and transitions. So, upon the onset of menses, individuals can experience shifts in their sense of identity and their sense of independence. They can develop increased awareness of their body and potentially experience more internalization of stereotyped gender roles. A menstruating individual also experiences the peak of fertility roughly about the same time that careers are often at a pivotal point. There can be a pressure to prioritize either family or career, but not both. And individuals may experience a lack of support from family or the companies that they work for when they're at this combined peak of fertility and pivotal career points. So it can be this kind of difficult moment where you have to, for many individuals, decide which do I prioritize now. There can also be shifts in social relationships that occur, especially when individuals become pregnant and the relationships may change with friends or family, or if an individual is experiencing infertility and friends or family around them become pregnant, that can be a very changing time in that social relationship. Menopause can also prompt individuals to reassess their values and priorities a bit, potentially make changes to their life if they feel like their values or what they want to have as priorities are shifting once their childbearing years have ended. And there can also be this altering of social interactions. So, menstruation and pregnancy can change how individuals experience product marketing, the healthcare system, and the use of public bathrooms for sexual minority women and non-binary individuals. So, kind of throughout the reproductive lifespan, there are these social changes and transitions that occur. We're going to transition to our section covering perinatal mood and anxiety disorders. I'm going to begin with an overview of premenstrual disorders before I go into the baby blues, postpartum depression, generalized anxiety disorder with a postpartum onset, and perinatal anxiety. And then I'll cover screening, assessment, and treatment for these conditions. So I want to get a sense of, for all of those who are attending live, what are the premenstrual disorders that you have heard of to this point in time? Please feel free to put it in the chat of which letter might correspond with your experience. We've got a lot of C's, so PMS and PMDD. Someone who has heard of PME, hasn't heard of any of these, but looks like there's a lot of C's. So PMS and PMDD seem to be most common, but we definitely have some people who have also heard of PME, which is really, really cool. Right. So a very good mix of people who've heard of PMS and PMDD, but also some people who have heard of PMS, PMDD, and PME. Wonderful. All right. Well, for anyone who hasn't heard of these, we will be going through them, but thank you all for putting that in the chat. So as we start our discussion on the premenstrual disorders, I wanted to spend a little bit of time going over just the physical and emotional symptoms that can occur in the premenstrual time phase or time period. So there's about 25 most common symptoms that individuals who are experiencing premenstrual symptoms can have. With regard to physical symptoms, individuals can experience abdominal cramps, joint or muscle pain, headaches, fatigue, weight gain, bloating, breast tenderness, acne, changes to their gastrointestinal habits, nausea, anemia, and muscle tension, among others. These are just kind of the more common ones. So many physical symptoms that are not comfortable and can be intense. And with regard to emotional symptoms, people can experience increased anxiety, increased depressed mood, increased crying, mood swings, apathy, being more irritable, changes in their appetite or food cravings, changes in their sleep, social withdrawal, poor concentration, and changes in libido. So lots of different physical and emotional symptoms that individuals can experience during the premenstrual time. We're going to start off with a discussion of premenstrual syndrome, or PMS. So PMS is the combination of physical and emotional symptoms that happen starting most commonly after ovulation and before the start of menstruation. Now, the diagnostic criteria requires at least one physical symptom and one psychological symptom that are present in the 5 days prior to menstruation. So there's a lot of room within that diagnostic criteria for individuals to experience maybe only 3 symptoms or 24. Because the diagnostic criteria only asks for one physical and one psychological symptom, there's a lot of room for people to experience mild or more intense symptoms that still fall within the PMS criteria. Current research indicates that as many as 75% of women can experience PMS symptoms at some point during their reproductive lifestyle, and up to 75% of menstruating individuals experience the PMS symptoms and the premenstrual symptoms that can last anywhere from a few hours to a few days during that premenstrual time. One of the leading hypotheses for the onset of PMS, sort of why it starts when it does, is the hormone fluctuations, as well as serotonin fluctuations that may be present within the individual. I'm next going to cover premenstrual exacerbation syndrome, or PME. PME is the exacerbation of symptoms of a mood or anxiety disorder that occur during the luteal or premenstrual phase. So there are symptoms of an affective disorder that are present throughout the month, but are notably worse during the luteal phase and the first few days of menstruation, and then improve and have symptom relief after menstruation starts. So PME is really this amplification of the existing symptoms of the affective disorder, but it does not introduce new symptoms. So there's no new psychological or physical symptoms that are being introduced during the premenstrual phase. It's really just this amplification of the symptoms that are already there. PME has mostly been explored in research settings only, and it's just barely starting to come into clinical practice. So I'm glad that we have some people in attendance today who have heard of it, because PME can also offer a little bit of an explanation for an increase in symptoms in a wider range of conditions. PME can exacerbate and impact symptoms of anxiety and depressive disorders, but there's also research showing that PME can influence other mental health issues like substance use, eating disorders, borderline personality disorder, schizophrenia, and PTSD. So to give an example of how PME might manifest with an eating disorder, so if someone is experiencing anorexia and they have PME, this can look like an intensified body image disturbance, heightened anxiety around food and their weight, and increased restrictive eating in that luteal and premenstrual phase. If an individual has a diagnosis of schizophrenia and experiences PME, it can manifest as more frequent or intense psychotic episodes, more difficulty forming coherent speech or linear thoughts, a sharper decline in motivation or social engagement, and potentially more noticeable impairments in memory. So PME can impact more than just the mood and affective disorders, but the research is really backing at this time its impact on affective disorders. It's still being researched to also really fully differentiate how it's distinct from PMS and PMDD, but it's helpful to know as clinicians and providers that it does exist. Next, I'm going to go over premenstrual dysphoric disorder, or PMDD. And it sounds like a lot of the people we have in attendance already know a little bit about PMDD, so this may be a review for some of you, but new for others. So the symptoms of PMDD are more severe than those of PMS, and the symptoms tend to begin after ovulation during the luteal phase, and then usually go away within a few days after menstruation starts. The symptoms of PMDD can include the physical and psychological symptoms that we covered at the beginning of this section. However, PMDD can also include feeling out of control, an increased sensitivity to rejection, sudden feelings of sadness, swelling of the extremities, and forgetfulness. The criteria for PMDD includes at least one more intense psychological symptom of either marked lability, marked depressive mood, and/or marked anxiety, and the individual has to have at least one of the following physical symptoms: anhedonia, reduced concentration, lethargy, appetite change, sleep change, and the presence of physical symptoms of premenstruation. So with those more intense psychological symptoms and the physical symptoms, it often culminates in much more severe anxiety and depressive symptoms in individuals with PMDD. And up to 35 or 34% of individuals with PMDD report a past suicide attempt, and they're more likely to experience self-harming behaviors. Dr. Crowell will go into self-harm and suicidality a little bit later on, so I'm not going to cover that in this section, but I wanted to kind of make sure to note that there is this increase in suicidality and the risk of self-harming behaviors for individuals with PMDD. About 3 to 8% of reproductive age menstruating individuals have diagnosable PMDD. But research has shown that up to 20% of individuals have clinically significant symptoms, but potentially have not received a PMDD diagnosis for whatever reason. PMDD most often has an onset when individuals are in their 20s, but it can onset as early as adolescence, and it's often exacerbated by reproductive events such as menarche, pregnancy, birth, miscarriage, and menopause. So any of these kind of bigger reproductive events can really exacerbate symptoms of PMDD, or especially with menarche, can cause the onset when individuals experience PMDD in adolescence. To review some of the risk factors that exist for PMDD, it includes a history of mood or anxiety disorders, family history of PMDD, high levels of stress, and being an individual who menstruates in your late 20s to mid 30s. So we can't exactly control our age as a risk factor, but the individuals within their late 20s to mid 30s are sometimes at a higher risk of developing PMDD. I also want to highlight that PMDD was only added to the DSM-5 as a depressive disorder in 2013. And in 2019, only about 7 years ago, the World Health Organization added PMDD to their international classification of diseases. So it wasn't until 2019 that there was this major acknowledgement that the menstrual cycle could trigger such severe psychological symptoms and cause impairment at the same level as more chronic mood disorders. So 2019 was a big win for the reproductive field, but that was only 7 years ago. I also wanted to touch on and go over a few of the leading theories of why PMDD happens. So there's not one conclusive, definitive origin of PMDD, but there's a lot of strong theories that are currently being researched. So one of the more leading theories is that it's triggered by the changes in estrogen and progesterone that occur during menstrual cycles. And more severe PMDD is potentially related to an increased hormonal sensitivity. So when individuals have increased hormone sensitivity and then they experience these changes in estrogen and progesterone during their menstrual cycle, particularly during that luteal phase, it kind of triggers these symptoms. There's also been a possible theory that's being worked on that it might be an abnormal serotonin neurotransmission where there's lower density of serotonin transporter receptors. It's also being investigated as possibly originating from an altered gene complex that changes how the body responds to hormones and stressors, or how the body responds to the exposure and then withdrawal of ovarian hormones. So, very interesting theories, but there is not one that has been definitively shown or definitively kind of proven as being the origin of PMDD. I also wanted to add this important note that as we're talking about PMDD and how it's impacted by these hormone fluctuations, to go over the implications with hormone therapy, particularly starting, stopping, or changing doses of a hormone therapy. There have been recent studies that have shown that the adverse emotional reactions that can be caused by starting or adjusting hormone replacement therapies tend to go away after about a month or so. So, if the individual who's on a hormone replacement regimen or hormone therapy regimen is able to tolerate the symptoms of the emotional reaction, kind of this increase in emotional symptoms, for about a month or two, the symptoms usually go away and the overall fluctuations of those psychological symptoms can decrease. I also wanted to highlight that there is no definitive research or current evidence to show a direct association between testosterone therapy and the onset or worsening of mental health conditions, including PMDD. And anyone with ovaries can have PMDD unless their menstrual cycle is being suppressed by medication or birth control. And so when medication or birth control is being used to treat PMDD, it can help mitigate the symptoms, but anyone with ovaries can experience PMDD. And in some individuals who are assigned male at birth, there are some hormone therapies that can induce symptoms that are similar to PMDD if that individual already has an existing hormonal sensitivity. So, similar to how individuals who are assigned female at birth may have this existing sensitivity to those hormonal fluctuations, individuals who are assigned male at birth and then are on some hormone therapies can have similar symptoms to PMDD if they're already sensitive to the hormonal fluctuations. Okay, I have another poll for you all. I'm curious to hear what you all think is one of the most important things to be aware of to help with a differential diagnosis between premenstrual disorders. So we've got the frequency of symptoms, age of onset, when the symptoms happen through the cycle, or none of the above. All right, so we got a lot of people chiming in. That's when the symptoms happen throughout the cycle. So one, none of the above. Lots of people saying C. Yeah, so pretty strong cohesion that when symptoms happen throughout the cycle is one of the most important things to be aware of. And spoiler alert, that is definitely one of them, and the answer that I had in mind. So to go into a little bit about the differential diagnosis between premenstrual disorders, it is really crucial to look at when during the menstrual cycle the symptoms occur, when they increase and when they decrease. For PMS and PMDD, the symptoms both usually go away within a few days of the start of menstruation, but PMDD symptoms are often more severe and can onset slightly earlier than PMS. Individuals with PMS are still able to function largely normally, but individuals with PMDD can have more negative impacts on their work, relationships, daily life, and overall well-being. And individuals who experience PME, those symptoms are present throughout the month, but are notably worse in that premenstrual phase. So yeah, just a little bit about the differential. It's really about the timing and the severity of the symptoms, but really getting a sense of when the symptoms are increasing and decreasing is crucial to be able to start that differential. We're going to switch gears slightly into the perinatal mood and anxiety disorders, starting with the baby blues. The baby blues is a set of symptoms that occur within a few days after birth and can include mood fluctuations, increased irritability, increased emotional lability, anxiety, fatigue, insomnia, restlessness, weepiness, and poor concentration. These symptoms can last anywhere from a few minutes to a few hours each day and often lessen each day after delivery. And then most symptoms are gone within a few weeks after birth. The prevalence of baby blues is really high. So 50 to 85% of new mothers will experience the baby blues. And the leading theory of why these baby blues occur is due to the huge change in hormones that happen after birth. I wanted to offer a little bit of kind of the differential because there is a time period of normal adjustment to parenthood and having a baby and having a little newborn. And so these normal adjustments can look like fatigue, ability to sleep when the baby sleeps, feelings of overwhelm, ability to still experience pleasure and joy, anxiety that is relieved when given support or advice, and increasing confidence and comfort with caretaking. So when individuals are experiencing the normal adjustment to parenthood, they can be anxious and tired and overwhelmed, but those symptoms are often relieved or supported by others helping out. They're still able to experience joy and pleasure, and their confidence or comfort with caretaking increases. I wanted to add here that there is this time following birth where there's so much intersectionality occurring. There's massive hormonal changes and physical changes that are happening when the body's adjusting to no longer being pregnant. There can be the emotional issues with navigating if someone's experiencing normal adjustment, baby blues, or potentially even postpartum depression or other psychological issues postpartum, and the social changes that are happening. People want to meet the baby if the person's off work or not. So there is just this massive intersectionality that's occurring in the time right after birth. And there are also, in normal adjustment, these normative symptoms of anxiety and low mood that can occur following birth. But it's important to keep an eye on what the individual is experiencing, kind of how long it's going on for. Next, to go into postpartum depression. It's also referenced as PPD. So if I may use postpartum depression or the acronym PPD. So postpartum depression can occur anytime within the first year after birth, and it can last anywhere from a few months to a few years. So individuals may give birth, and then it's not until a month or two later that some of these symptoms start coming up, and it can last a really long time. The symptoms of postpartum depression include a depressed mood, anxiety, excessive guilt, difficulty feeling like they can connect with their baby, and difficulty sleeping when the baby sleeps, as well as overall negative impacts on sleep, withdrawing from friends and family, thoughts of harming oneself or the baby, and suicidal ideation. Between 5 and 14% of women with postpartum depression experience thoughts of self-harm. Dr. Krall will also be going more in depth on suicidality in the perinatal population towards the end of this presentation, so stay tuned for a more in-depth discussion on that. Now, postpartum depression is prevalent in between 10 and 19% of women, but it's possible that the numbers are higher if people are not seeking treatment or their postpartum depression is not at such a severe level that they're needing more notable intervention. So while we have research documenting this prevalence of 10 to 19%, it's possible it's a bit higher. There are also a lot of risk factors for postpartum depression. This can include the HPA axis dysregulation, or that dysregulation of the stress response system, genetic vulnerabilities, depression or anxiety that was present during pregnancy, high levels of stress, poor social support, a higher age, if an individual is diagnosed with hypothyroidism, and if the pregnancy was unwanted or unplanned. All of these different things can just increase the risk that someone may develop postpartum depression. And one of the key things when we're thinking about differentiating between baby blues and postpartum depression is really the duration of these symptoms. So, as I had just gone over with baby blues, those symptoms are present for a few weeks but are decreasing with each day and are usually gone within a few weeks. But if the symptoms are lasting longer, or if they're starting farther out of the postpartum time period when someone is farther out from birth, then it's more likely that that person's experiencing postpartum depression if those symptoms are really persisting or have a later onset rather than right after birth. I also want to talk a bit about perinatal anxiety and generalized anxiety disorder with a postpartum onset. So, perinatal anxiety, especially in research, is an umbrella term that really covers kind of any main anxiety disorder that can occur during pregnancy or up to a year postpartum. Dr. Hopkins will be going into perinatal and postpartum OCD in her section of our presentation today. So, for my slides, I'm really just going to be focusing on generalized anxiety disorder with a postpartum onset. So, generalized anxiety disorder, or GAD, with the postpartum onset is the start of symptoms that meet criteria for GAD but are starting after childbirth. Symptoms of kind of this broad perinatal anxiety and GAD with a postpartum onset can include excessive worry that only slightly is relieved with reassurance or support, difficulty relaxing, muscle tension, a lot of worry around the baby's health. Is the room too hot? What's their temperature? Do they have everything they need? Just a lot of these worries around the baby's health, feelings of overwhelm related to caretaking, insomnia that's secondary to their anxiety symptoms, and depressive symptoms that are also secondary to anxiety symptoms, and rumination. I wanted to clarify a little bit kind of the definition and what falls under rumination. So, rumination is this constant repetition of a negative thought or a negative theme that can impact our mood and even our physical health. Sometimes rumination is this process for individuals of trying to go over something that happened in the past, trying to gain insight into it, or problem solve something in the future, predicting an outcome, or worrying about something that might happen. And rumination is a symptom that co-occurs in both anxiety and depressive disorders, and is a primary symptom in OCD and generalized anxiety disorder diagnostic criteria. But particularly kind of within this perinatal population, rumination is one of the symptoms that is seen a little bit more often. With regard to prevalence, GAD with a postpartum onset is prevalent between 4.4 and 10.8% of mothers in that postpartum period. And perinatal anxiety has a slightly higher prevalence of 8.5 to 10.5%. But it's very likely that that higher prevalence is because perinatal anxiety is just a broader term. So more individuals experiencing anxiety in or around childbirth and their postpartum time period can kind of be included under the perinatal anxiety prevalence. Like with most things that we've talked about so far today, there is a degree of anxiety and worry that can be normative during pregnancy and postpartum. However, perinatal anxiety and GAD with postpartum onset are when these symptoms become more intense and have more negative impacts on the individual's mental and physical well-being and really start to impact their daily life. Okay, so next we're going to kind of shift gears into learning more about screening and assessment before we dive into some treatment options. So when we're screening for premenstrual disorders, there's a couple different options that we can use to assess the intensity, duration, and onset of symptoms. The main screeners that are supported by research are the Carolina Premenstrual Assessment Scoring System, the Daily Record of Severity of Problems, the McMaster Premenstrual Mood and Symptom Scale, and the Premenstrual Symptoms Screening Tool, which has both an adolescent and an adult version. The Daily Record of Severity of Problems is the most commonly used from what I've seen, and as I was preparing for this presentation and learning about these and kind of my own experience, but it does require a daily record of the symptoms that someone's experiencing. And when we're screening for these premenstrual disorders, we really want to have the individual track symptoms for at least 2 cycles, because these premenstrual disorders are really influenced by hormone changes and hormone fluctuations. If we only look at 1 cycle, we're not going to get the full picture. But if we're able to have the individual track for 2 or 3 cycles, we're able to get a much better sense of what the fluctuations are, what patterns of symptom increase or symptom decrease are present for the individual. And so if it's maybe unfeasible for someone to track every day for 2 or 3 months with this daily record of severity of problems, the other screeners are a little bit less daily recording, and so they can be sometimes more accessible and have kind of a lower barrier to entry for people to begin filling out. To screen for baby blues or postpartum depression, the Edinburgh Postnatal Depression Scale is the most commonly used one. But there are also the Postpartum Depression Screening Scale and the Rosenberg Self-Esteem Scale, which are both empirically validated as screeners for postpartum depression. Perinatal anxiety is a bit harder to screen for, but there is the Perinatal Anxiety Screening Scale. It's important to note when we're thinking of screening for this perinatal anxiety or generalized anxiety disorder with a postpartum onset that the GAD-7 questionnaire is not sensitive for postpartum anxiety. So if you're wanting to assess if someone's maybe experiencing this perinatal or postpartum anxiety, the GAD-7 is not going to really be able to pick it up. So we'd want to use another screening option like the Perinatal Anxiety Screening Scale. I also want to go over a few kind of general assessment guidelines for the assessment of premenstrual disorders. It's really important when we're trying to assess and understand the individual's experience to really assess the degree of impact that these symptoms are having. So how intense are they? What areas of their life are they impacting? And if these mood or affective symptoms lessen during other parts of the cycle or have more fluctuations. So really kind of getting this overview of what is the individual experiencing. And when we're assessing for perinatal or postpartum anxiety, baby blues, and postpartum depression, there are a number of really important questions that we as providers can ask to more accurately assess and understand the individual's experience. So we really want to assess for if there were any physical complications or physical illnesses that occurred during the pregnancy. If emotional or mood symptoms like anxiety or depression were present during the time that the individual was pregnant. If the pregnancy was planned and or wanted. What type of delivery the individual had. So was it a planned delivery or was there something that happened that caused it to be an emergency delivery or unplanned? And if it was not a planned delivery, what happened that caused it to become that emergency or unplanned delivery? If there's any postpartum physical health issues for either the birthing parent or the baby, physical things that are happening after childbirth, how that bonding is going with the baby, if the individual is able to feel connected or if there's difficulty feeling connected with their child. If the parent is able to be on leave or if they have to go back to work pretty soon after delivery. And we also want to be able to assess what the feeding experience is. Is the individual breastfeeding, using formula, or a combination? So these kind of questions can really help us understand not only what the person's experience is like, but also what risk factors or stressors may be present that might kind of be flags for the potential of postpartum anxiety or postpartum depression. And it's also incredibly important when we're assessing for the possibility of postpartum depression or postpartum anxiety to always assess for suicidality and self-harm. All right. So next, some of the more fun parts, the nitty-gritty is the treatment options. So for premenstrual disorders like PMDD and PME, there's a good number of pharmacological treatments that are available. Medications like antidepressants, anti-anxiety medications, or over-the-counter pain relievers are most commonly used pharmaceutical treatments for PMDD and PME. Depending on the physical symptoms that someone is experiencing, diuretics can also be used to help with bloating and constipation and water retention. And as I had mentioned earlier, hormonal contraceptives are often used to manage the symptoms of premenstrual disorders because they can be used to help manage the hormone fluctuations that occur. SSRIs are particularly helpful to manage depression symptoms in premenstrual disorders, and there can be these altering of the medication dose depending on when the symptoms onset. So medication providers or psychiatric providers can use continuous dosing, where the individual is taking the medication throughout their cycle, intermittent dosing, where they're only taking their SSRI or antidepressant during the luteal phase, or semi-intermittent dosing, where they're on some dose of antidepressant or SSRI throughout their cycle, but then they have an increased dose during the luteal phase. Sertraline, fluoxetine, and paroxetine hydrochloride have been actually approved by the FDA to treat PMDD. I'll add the asterisk here that PME does require treatment throughout the cycle, and research has shown that it doesn't tend to respond as well to the intermittent dosing, so that dosing only taking medication during the luteal phase. So PME does really need either the continuous dosing or the semi-intermittent, where there's an increased dose during that luteal phase. The pharmacological treatments for postpartum depression can include antidepressants like sertraline or fluoxetine that are safe to take while pregnant or breastfeeding, but be sure to work with medical providers and kind of anyone who does medication prescribing to determine what medications might work given individual factors and the individual's physical experience. There are two kind of pharmacological treatments for postpartum depression that I wanted to note. So brexanolone is a fast-acting medication that can be used to treat more intense postpartum depression. However, it's very expensive and requires hospitalization in order to be administered. So there's a lot of issues with accessibility to this medication. And zuranolone is also a fast-acting medication for postpartum depression, and it's a 14-day course, but it's a lot more accessible because you don't need to be hospitalized, and it's a little bit less expensive than the brexanolone. There's also multiple psychological treatment options for premenstrual disorders and postpartum anxiety and depression. Dr. Hopkins is going to dive more into ACT and CBT, and Dr. Crowell will be talking more about rumination-focused CBT and DBT. So I'm really introducing these as treatment options before we have more in-depth discussion later on. ACT, so acceptance and commitment therapy, can help individuals to increase their mindfulness related to hormone cycles, develop more acceptance of the self as it is, and decrease resistance to engaging in self-care, particularly for those premenstrual disorders. It can also help new parents accept difficult thoughts and difficult emotions without engaging in that negative judgment towards themselves. And ACT can even help reduce emotional distress and promote connection between the parent and the baby. CBT, or cognitive behavioral therapy, can help individuals to engage in cognitive reframing related to working to nurture the body rather than fighting against the changes, and address any cognitive distortions that may arise related to their body or their experience. And CBT, as a fun fact, has been shown to be as effective as fluoxetine for the treatment of PMDD. DBT, or dialectical behavior therapy, can be useful in assessing the individual's current coping skills, whether effective or ineffective skills, help them to recognize and establish their boundaries, support them effectively asking for help when they need it, increase their mindfulness skills, and improve distress tolerance. And psychoeducation is kind of a tenet of ACT, CBT, and DBT, but I wanted to add it as its own kind of treatment here because helping the individual understand more about the influences and the impacts, the symptoms that they might be experiencing, and the biological origins and those physical considerations can really help the individual just feel a little bit more equipped, where they have more of their information in their toolbox, where they know more about what's happening within their own systems. And the last treatment I'll go over is kind of these behavioral treatment options. And so these are like the behavioral or lifestyle factors. So there's a lot of research that shows for premenstrual disorders that decreasing alcohol or nicotine, reducing salty and sugary food intakes, increased sleep quality and quantity, regular exercise, and engaging in self-care activities are really helpful to promote psychological and physical well-being and can even help alleviate some of the symptoms of PMS, or those premenstrual symptoms. There are research that exists that there's some vitamins or herbal supplements that can be used for managing premenstrual disorders or perinatal mood and anxiety disorders, but the research is minimal and is not well-founded. So if you're working with someone or you yourself are interested in vitamins or herbal remedies as possible treatment options, please do consult with your medical provider or a medical doctor before beginning herbal or vitamin supplements or remedies. All right. And I will now turn it over to Dr. Hopkins to continue our discussion today.
Thanks so much, Rachel. I'm going to get our screen share going again. So just give me a moment to do that. And there we go. I'm lucky because I get to be your second Rachel presenter of the day. But just to spend a really brief moment to introduce myself. My name is Dr. Rachel Hopkins. I am the program director of our anxiety and mood team here at UCEBT. But I physically live and work in Colorado. I have an in-person office in Colorado Springs, and I'm also a mom. I have a really fun and sweet and spunky 10-month-old who is all over the place right now and is keeping me on my toes. So the topics that we're talking about today are really near and dear to my heart. And the two main things that I'll be focusing on in my time with you today are OCD, as well as reproductive trauma, grief, and loss. Both are deeply important to me. I specialize and work with folks with OCD a lot, and just really noticed more and more folks coming in with perinatal or postpartum onset of OCD symptoms, or a real shift in their OCD symptoms when they were in the perinatal or postpartum period. And, you know, as therapists, we all have our origin story. And so working with grief and loss is really a big part of my origin story as a therapist. And so again, just a few topics that feel really meaningful and important to me. And because we're together today for 3 whole hours, I just figured I'd take a moment for us to check in. So take a big, deep breath. And a big exhale, full breath in, complete breath out. And then maybe also stretch your neck. Your arms. Any other places of tension or tightness that you might be noticing in your body. And just a reminder to take care of yourselves today. Take care of yourselves always, please. But while we're here together, please take care of yourselves throughout the presentation. Sometimes the topics can feel heavy, or sometimes we just get excited and notice ourselves holding our breath as we're ingesting new information. So we'll start by talking more about perinatal and postpartum OCD. And I really, really appreciate, Dr. Armstrong, your introduction into our anxiety disorders. I feel like it really helps set the stage. And yeah, really excited to talk about one very specific anxiety disorder. So before we get into any specifics around perinatal or postpartum OCD, I think it's a really good idea to make sure we have a solid foundation on our diagnosis in general. So this is our DSM-5 diagnostic criteria. OCD involves the presence of obsessions, compulsions, or both. And one of the distinguishing factors between OCD and other types of anxiety disorders really is the presence of those compulsions. So, obsessions are intrusive thoughts. They tend to be recurrent, persistent. They can be thoughts, urges, images, memories. They tend to be unwanted or ego-dystonic in nature, so people can find them disturbing and they're not enjoyable thoughts to be having. They cause significant anxiety or distress for the person, and they're often attempts to ignore, suppress, or neutralize those thoughts. And so, from a functional perspective, what compulsions do is they act as the neutralizer. Compulsions are repetitive behaviors or mental actions that are in response to those unwanted, intrusive thoughts, but they tend to be rigid and very rule-based. The function or the goal is to reduce the anxiety or distress that people are experiencing, but they're either not realistic, meaning the thing the person is doing wouldn't actually have an effect on that worry, or they are excessive in nature. These are very, very time consuming for people. So there are different severity intensities based on the different amount of time that it takes, but at least 1 hour a day. And it could be significantly more than that. And it's a pretty common diagnosis, 1.2% lifetime prevalence rate in the United States. OCD is really cyclical in nature. So these obsessions and compulsions interact with one another. The compulsions feel like they're going to help, and they do provide some very temporary short-term relief, but they also make obsessions worse over time. So I usually use a mosquito bite analogy to describe this to people. So if you've ever had a mosquito bite before, you've probably experienced this where you're like, oh, shoot, there's a mosquito bite on my arm. And you probably say to yourself something like, don't scratch it, don't scratch it, don't scratch it. But of course, if you do scratch it, what is the first thing that you feel? That very, very first thing. You get lots and lots of relief usually. Ah, that felt good. I don't have a itchy feeling there anymore. But any of us who have had a mosquito bite that we have scratched before, which I'm pretty sure is any person who's had a mosquito bite, not positive though, knows that that relief does not last forever, nor does it tend to last a very long time. And typically, what happens when we scratch the mosquito bite is that itchy feeling comes back with a vengeance. It comes back even stronger, and sometimes to the point where we even keep scratching and we start to bleed or maybe have a scar there in the future. And this is really the same way that OCD works. We have an obsession or an itchy or sticky thought. We scratch it by engaging in some kind of compulsion or ritual or safety behavior. We get really short-term relief from that, from that thought that's really unpleasant and unwanted. And then long term, it comes back with a vengeance. And so that's really what maintains our OCD symptoms over time. I'm just gonna pull our chat up real quick just to check in. Okay. For perinatal or postpartum OCD, this is really a theme or a type of OCD that is centered around a baby or the baby. There is an increased risk of developing OCD symptoms while pregnant or postpartum, so going up from that 1.2% prevalence rate to 2 to 3% of all parents. And there are a lot of vulnerability factors that can contribute to this. So hormone fluctuations, increases in stress, increases in responsibility, lack of sleep, loss of routine, huge amounts of changes are occurring at this point in time for people. And many of those things, even if it's for really positive reasons, are still considered vulnerability factors. I also want to highlight that intrusive thoughts are incredibly common for new parents, but postpartum OCD is different. So research says 70 to 100% of new moms have intrusive thoughts of some kind, and even about infant harm. But for most of those thoughts, we might have that thought pop into our head and we say, that's a weird thought, and move on with our day. But for OCD, like I said, it's the sticky, intrusive, unwanted, and it really starts to take over of life. I want to highlight, because it can be kind of taboo to talk about, that many of the themes of postpartum and perinatal OCD do have to do with harm coming to the infant or causing harm to the infant. And just to normalize, 50% of new moms have intrusive thoughts that are within that theme. It's a really common way that OCD shows up, but it is also a common intrusive thought in general. And sadly, misidentification of OCD by healthcare professionals, so not even just in the general population, is really common and can lead to harmful interventions. So up to 50% of non-psychiatrist physicians may misidentify OCD, and up to 80% misidentifying harm obsessions specifically. Almost 70% of perinatal health practitioners did not accurately identify obsessions around harming the infant, and 30% misidentified these symptoms as psychotic. And as many as 58% of perinatal health professionals recommended contraindicated strategies. So these might include things like a violence risk assessment, recommending that somebody else care for the baby, involving child protective services, or prohibiting the mother from being alone with the infant, or even prescribing antipsychotic medications rather than therapy or SSRIs. And just an important note that fathers and other non-childbearing parents are not immune to the new onset of intrusive thoughts and OCD during the perinatal or postpartum period, but most of the research that we're talking about today, like Dr. Armstrong said earlier, is talking about moms, women, but not immune. Okay. So as I mentioned, for perinatal or postpartum OCD, this is a theme that centers around the baby. The exact symptoms can vary a lot from person to person, and so it's always best to do a thorough assessment by a licensed professional. But a lot of them do tend to follow general patterns of symptoms. It's possible that a person has had OCD prior to their pregnancy, and those symptoms really just shift focus to the baby. But it's also possible for OCD to be triggered by pregnancy or giving birth. And so a person might not have had OCD before, and then the onset of these symptoms is in the perinatal or postpartum period. Some common obsessions include things like worry thoughts about harm coming to your child, health and safety concerns, your child getting lost or kidnapped, sexual obsessions, or even causing harm to your child. And just again, a reminder that these thoughts are unpleasant, unwanted, and ego dystonic. Compulsions, or that neutralizing or ritual behavior, can include things like excessively checking on the baby, which is much, much easier to do now with all of the technology that exists. And so if you have clients or patients where you suspect that OCD might be present, you might want to check in about what use of technology they have. Video monitoring, or those little socks that you can put on their feet that measure things like respiration and heart rate and things like that. It could include a lot of avoidance. So not being with the baby alone, or not holding the baby, or bathing or changing the baby. Lots and lots of excessive research about worries, particularly for things that don't have clear answers to them. Repeating prayers or affirmations of care, like, I'm a good mom, I'm a good mom, I'm a good parent. Seeking reassurance from others, so a partner or a friend or another loved one. Hiding knives or any other objects that we might perceive as dangerous, and intense efforts at thought suppression. And so you might imagine that not only if you're in this postpartum period where you have a new baby, maybe you're up and feeding them every 2 or 3 hours throughout the night, your sleep is already disrupted. But then on top of that, you're engaging with hours of compulsions or rituals or safety behaviors. And so both OCD and postpartum or perinatal OCD really are exhausting and cause significant impairment in a person's life. So I want to go through a couple of examples just to help with that identification piece. And if you're willing to type some answers in the chat, we can all kind of learn and brainstorm together. So if you had a client who you suspected postpartum OCD for, and you were noticing some themes around either contamination or health and safety, perhaps they had a worry thought about the cleanliness of a bottle. Like, what if the bottle I'm feeding my baby from isn't clean? What do you think might be some compulsions or rituals that that parent would be engaging in that you could keep an eye out for? Yeah, excessive cleaning of bottles. Yeah, repeated sterilizing or cleaning of bottles, not trusting others to clean bottles. Yeah. Yes, repeated checking. Absolutely. Yes, researching. I was just about to say that one too. What are the best ways? There's all sorts of gadgets out there to sterilize, store, and clean bottles too. Yes, seeing, or I've heard people describe feeling germs before as well. And cleaning even other places in the house, or washing hands. Yeah, reassurance. Awesome. Great job. Okay, what if there was a theme around harm or aggressive, unwanted, intrusive thoughts toward the baby? So um, what if I what if I secretly want to drown my baby? What compulsions or rituals might you see that parent engaging in? Yeah, avoidance of the bath or being alone. Not bathing at all. Avoiding being alone with the baby. Yep. Places that are perceived as dangerous, reassurance seeking, having spouse carry the baby or take over care. Yes, checking that they did not cause harm. Beautiful. All right, you've all got this. And just one more, because it does tend to be a pretty taboo topic, but it's also really common. So sometimes our OCD themes can be sexual in nature. What if I secretly want to touch my baby inappropriately? Or what if I touched my baby inappropriately or harboring some secret desire to touch them? Yeah, avoiding changing diapers, avoiding bathing, or holding the baby. Y'all are pros at this now. They might also just a couple of other ones. Yeah, no skin to skin. That's a really great example. They might yeah, checking either verbally or internally. I've had lots of folks sort of rehearsing past interactions with the baby in their mind, and then, engaging in excessive reassurance seeking, either from another person or for themselves internally. All right, you've all got this. You will not be among the providers who misidentify postpartum OCD. Beautiful. And so I'll breeze over this because unfortunately there just really isn't very much research on screening measures that are validated for this population. Um, Dr. Armstrong already went over the perinatal anxiety screening scale, which is really important to know that there are also some questions about obsessions and compulsions here. And then the gold standard for OCD screening in general is the Y box, the Yale-Brown Obsessive Compulsion Scale. And it's really important to know that that does come with a symptom checklist. So I've seen it before where providers have only administered the portion that asks about symptoms and symptom severity, but the checklist is really a really great screening measure for asking about a wide variety of symptoms and really being able to map out and figure out all the places where OCD is hiding out. I also added the OCI measures are validated with the perinatal population and are ultra brief screening tools, so are sometimes helpful to use in more of a medical setting or a setting where you can't do more in-depth assessment. And then comorbid depression is incredibly common with OCD because of how life impairing it is. And so PHQ-9 is one example, but some kind of depression screening measure as well. Treatment-wise, exposure and response prevention it's a type of CBT and it is the gold standard treatment for OCD. Essentially, it involves gradually and intentionally exposing yourself to triggers or cues, and then making the choice to not engage in the compulsion or ritualistic behavior. But there are steps before we do that. So like many therapies, we always start with psychoeducation. We'll start with some skill building. We'll map out OCD, make sure we know all the places where it's hiding out. We'll then create that exposure hierarchy, do the exposures, and then my favorite part, we call it living the exposure lifestyle, which is really when people are either nearing the end or complete with treatment, figuring out the ways that they're going to continue to engage in exposures on their own or just continue to make brave and courageous choices every day so that OCD does not come back. There's lots of emerging research coming, but currently acceptance and commitment therapy and DBT are considered either second line or adjunctive treatments. ACT especially has a lot of research behind it. And personally, I describe it as my first therapy language, and so I have a deep love for ACT. But I find it to be really helpful with this population for treatment engagement. What is really the why or the reason behind why you would do this very, very hard and uncomfortable thing can help with increasing motivation for treatment and really living your life more freely and more flexibly. So making the amount of time that OCD is in charge much smaller and the amount of time that you are in charge much bigger. It's also great with an inhibitory learning approach. And so for OCD treatment, sometimes our goal is to reduce distress level, but distress level does not always reduce when we're doing exposures. Sometimes the distress remains. When that happens, though, treatment can really still be successful when a person experiences some kind of new learning and new experiencing from engaging in that hard thing. So, wow, I felt really uncomfortable when I was bathing my baby, but also I realized I could do it even if my partner wasn't home. Or I realized even though I was feeling anxious, I also had a couple of moments where I was laughing and giggling with my baby when I bathed him. And then, like any other kind of exposure therapy, it really does increase distress level. And so we want to make sure that people have sufficient skills to be able to manage and tolerate that distress. And so, for many people, something like DBT, which focuses a lot on emotion regulation and distress tolerance, among other skills, it can be a great prerequisite to engaging in exposure work to build that foundation, particularly if emotion dysregulation is too high to engage in exposures, or if there are other kinds of skills deficits that are present. Medications for OCD. So according to the US FDA, SSRIs, and the ones that are listed here are the ones that are approved for use in general with OCD. And there is a little bit of research out there that sertraline or Zoloft or paroxetine or Paxil are more effective in the perinatal or postpartum population. And according to the CDC, it may be safe to take antidepressant medication while breastfeeding. Sometimes you'll see folks coming in with concerns to either transmission to the baby or how it might affect their milk production or milk supply if they are breastfeeding. And so what the research I found was said, although I'm not a prescriber or medical provider, that these medications may pass into the breast milk in very, very small amounts, but most have little to no effect on milk supply or infant well-being. But it's really important to do a consultation with a really qualified provider. Finding qualified providers can be hard. That overlap of folks who work with perinatal or postpartum population and also have training in OCD. And the same is true in finding a therapist as well. Support groups can also be helpful, and one of my favorite resources is the International OCD Foundation, or the IOCDF. There's a huge online community there, and there's all sorts of things in addition to support groups. There are walks and conferences. There's support for family members of people suffering from OCD, and all sorts of ways to engage and be a part of the community. And it can really help with feeling less alone, feeling less afraid of these thoughts that are coming up, meeting others, learning tips and tricks. But it's not usually a replacement for treatment. So that's important to keep in mind. Okay. So I'm going to introduce a case here, and hopefully we'll be able to continue to check in about this case throughout. So this is Lauren. And I want to just mention that this is an amalgam of clients that I've seen over the years. Any likeness to any one individual is purely a coincidence, because this is truly a makeup of many, many people combined. But OCD symptoms tend to be pretty similar thematically, and so it's possible that they're just very similar symptoms and maybe a person that you've heard of, worked with, or known. Lauren's in her early 30s, white, cisgender female, heterosexual, and is married. She's religious. She's Christian. And currently, when I started seeing her, had one child. She did have a history of OCD and anxiety symptoms. And when I saw her, her Y-box was in the moderate range, but her PCL, which is a PTSD screener, was below the cutoff or below the threshold. And the context in which I was seeing her was following multiple miscarriages in trying to conceive for a second child. She had experienced early on a failed D&C, which is a medical procedure to remove tissue from the uterus after a miscarriage, and was referred to me by another provider who had been taking a purely supportive counseling approach and felt uncomfortable both treating OCD, so referred out, and also was uncomfortable with some of the themes of OCD that were showing up. In terms of other important history, Lauren comes from a family that is very conservative, traditional, and patriarchal. And they were pretty invalidating of her experiences. They would say things like, why don't you go on a vacation? You seem pretty stressed. Might your stress be contributing to these miscarriages or causing these miscarriages? For herself, she delayed trying to conceive due to pursuing higher education. And so had a lot of concerns about her timeline for procreating, and then also the timeline between her first and second child. She had an idea of like, I really want the age gap to be this specific amount. Husband was really supportive, but she was isolating from friends and other family members because of worries about health and either her child getting sick or her getting sick and that causing another miscarriage, and was having and was feeling really misunderstood. She was also having really intense and persistent rumination about what might have caused the miscarriages. Or like I said, the age gap between her kids, lots of anger toward family members, jealousy towards friends or family members, kids and their age gap, and was engaging in really excessive self-blame. These are some of the themes of her obsessions and compulsions. And in terms of psychotherapy, we started with psychoeducation. We then moved into some ACT to help with treatment engagement and values-based decision-making, to help with self-compassion and acceptance of these really unwanted experiences that she had had. And we used both acceptance and change-based cognitive strategies, and we started ERP together. And so I'll keep checking in about Lauren as we move into our second topic here, but I wanted to sort of set the stage and have your brains primed to start thinking about her as we move into our next topic, which is a whole slew of things around reproductive trauma, grief, and loss. So again, checking in with our DSM-5 diagnostic criteria for PTSD specifically. PTSD develops when a person has experienced an event that involves actual or threatened death, injury, or sexual violence, and experiences symptoms in each of these four categories, at least one and sometimes two, depending on the category. So these are re-experiencing symptoms. These can include things like intrusive thoughts or memories or dreams or nightmares or flashbacks. At least one avoidance symptom. So this could be related to memories, thoughts, or feelings, but it could also be events, people, places, activities, situations that remind us of that traumatic experience. At least two cognition or mood symptoms. These can include things like negative beliefs about the self, others, or the world, excessive self-blame, negative emotions like fear, horror, anger, guilt, or shame, diminished interest in activities, detachment from others, and a lack of positive emotions. The changes in arousal or activity level symptoms, so at least two in this category, and it might include things like irritability, recklessness, hypervigilance or exaggerated startle response, difficulties with concentration or sleep problems. And these symptoms last for longer than 1 month and of course cause significant impairment. And one thing that we often say about trauma and PTSD is that all of these symptoms are normative reactions when a person has experienced a dangerous, scary, or life-threatening event. But when it turns into PTSD, we really think about it as non-recovery from those symptoms. And so the onset of symptoms can happen right away, but we wouldn't diagnose PTSD unless a person had been experiencing those symptoms for at least 6 months or longer. And in general, people feel intense fear, helplessness, horror. We'll sometimes use the phrase, this is a schema shattering event. So something that has really shifted or changed your entire worldview. Many, many, many people experience traumas, but not all develop PTSD. For reproductive trauma specifically, we would define this as the psychological distress experienced following challenges related to reproduction and fertility. This can involve mental and emotional changes, irritability, feelings of sadness, anger, guilt, or shame, mentally being consumed by fertility related thoughts, or you're feeling as though your future happiness is dependent on having a child. Physically, people can be experiencing reactions to medications or procedures. There could be significant physical pain or discomfort, or even just noticing differences in the body. My body feels different and not mine. Difficulty concentrating and decreased energy. And that psychological distress can also include relational distress, so social isolation from family and friends, distance from a romantic partner, decreased interest in sex or performance difficulties, and withdrawal. And when we're talking about reproductive trauma, the trauma stems not just from the physical experiences themselves, from, that actual or threatened death or dangerous experience, although it certainly can be, but from that shattering of our worldview, our expectations and dreams, or hopes or wishes for what we hoped the reproductive experience would be like. And reproductive trauma can encompass a really, really wide range of events, including infertility and miscarriage, pregnancy loss, stillbirth, birth trauma, and even medical interventions, including NICU stays. And so I felt it was important to be able to have some language to talk about these things as providers working with patients. Using really clear and concise and accurate language is incredibly important, both for validating the person's experience and for helping them process and have language of their own to describe what's going on. So I won't read all of these definitions, but they are here for you in the slides. A couple that I did want to add though, for infertility, there also are a couple of other infertility related concepts. One is secondary infertility, which is the inability to conceive or carry a baby to term after 12 months of protected intercourse after having previously given birth. So Lauren, our case example from before, would be experiencing secondary infertility because she already had one child. And then there's also something called social infertility, which is the inability to procreate based on relationship or circumstance. This is something that disproportionately affects single individuals, the LGBTQIA plus community, and those without financial means to access reproductive treatments. There are additional emotional and financial costs of family building that partnered heterosexual or high SES couples do not face. And it often involves a really wide range of medical procedures, emotional up and downs, and lots of loss reminders. Again, just like OCD, men and non-birthing partners can also experience reproductive trauma. And these losses and traumas do tend to be cumulative in nature, not a one-time event. So I think we talked through some of these examples, but if you think about those 4 PTSD DSM-5 diagnostic criteria, these would be some examples of how you might see it showing up in the perinatal or postpartum population. Again, themes or contents that are centering around pregnancy, reproductivity, babies, people with kids, things like that. And so these are not exhaustive, they are just examples for you to be able to sort of organize into those four criterion categories there. Following, of course, criterion A, which is the experiencing of an event, which this population has experienced many. Shifting slightly from trauma and PTSD over into grief and loss, there is a tremendous amount of grief and loss that can occur with this population. Grief, we know, is our emotional response to a loss, and they are universal and inevitable parts of life. But they are experienced very differently depending on culture and context. Every culture has its own way of grieving. And so you might ask yourself, or when you're working with somebody, or you might even ask for your own experiences related to grief or loss. What does the client's culture say about grief? What does my own culture say about grief? What rituals or practices do they have? Or how might those rituals or practices be incorporated into our work together? Are they engaging in any of those rituals or practices? And a lot of times, grief, it's not the thing that we are best at talking about in our culture, but there is some language for some types of loss that we experience. But for a person who is trying to conceive or who is struggling with their reproductive health in some kind of way, there's really not a lot of language, and people often struggle to know how to support those who are going through this type of loss or type of grief. And sometimes there can be a real impact on what that cultural or community support looks like because of lack of language or understanding. But it's really, really common. 10 to 20% of known pregnancies end in loss. 1 in 4 women lose a child during pregnancy or infancy. And those first two loss statistics are related to pregnancy loss specifically, but they do not capture those who are currently or who have struggled with infertility. And so it's really important to recognize that 12 to 15% of couples are also struggling with infertility. It's a lot of people. And so because we don't always have language to describe these types of losses, it can be really validating as providers to give a name to people's experiences. You'll see different terms out there in the literature. Disenfranchised grief is a grief or a loss that is not openly acknowledged, socially mourned, or publicly supported. You might think about this as an invisible grief where the individual is feeling it really strongly, but it's not necessarily seen or recognized as others. And that person isn't maybe actively being recognized as a griever. They're not being offered support or having people check in with them or bring meals or some of these things that we do when we know a person is grieving. And so this can include things like monthly menstruation, unsuccessful IUI or IVF cycles, early chemical pregnancy loss, or even later pregnancy loss. Can even include losses like never having been pregnant, that secondary infertility that we were talking about, failed or disrupted adoptions or foster care placements, and any kind of involuntary childlessness or childlessness not by choice. Secondary loss and ambiguous loss have a lot of overlap, but they're, depending on which definitions you're finding and looking, there are some ways to distinguish between the two of them. So secondary loss is considered are losses that are result of the death or the event rather than the death or event itself. while ambiguous loss is loss that occurs without a significant likelihood of reaching emotional closure or clear understanding. So secondary losses include things like loss of hope or belief around conception, or the belief that I might become pregnant one day. Loss of things that were previously enjoyable. Loss or changes in relationships of family and friends, especially while navigating pregnancy loss. And then ambiguous loss might include some of those things, but it also could include medical uncertainties or unknown causes of challenges with conception, pregnancy loss, things like that. And then there is complicated or prolonged grief. And this is grief that is intense. It lasts well beyond the period of social or cultural norms, and it's accompanied by impairments in daily functioning. This can involve things like intense and persistent yearning or longing or sadness, and either excessive attention towards thoughts and feelings about infertility, or really that loss or denial of or suppression of thoughts and feelings about the infertility. And so rather than going back and forth between these two states of grieving and moving forward, people are really stuck solidly in one of those states, either not being able to accept the reality of a death or loss, or really intrusive thoughts, persistent thoughts about that loss, and rumination focused on the circumstances and things like that. And so as we're moving into talking through some treatment options, one model for grief that we can think about and use is called the dual process model for grief. Having a model for grief helps us guide the client through the grief process, but it can also help us feel anchored, particularly when a person is coming in with high intensity or display of emotions, something that can help us feel anchored within ourselves, just like deep breaths or taking a stretch or something before diving into difficult content. And so the dual process model of grief really honors that grief is a hard, emotionally and physically exhausting experience, but that there's also a need for reprieve from that intensity. And moving back and forth between these two styles or two orientations for coping is what represents healthy grieving, or being able to process or work through grief. So both types of grief, or both processes that you see on the screen here, are important and healthy and normal. But unlike prior models of grief, it really gets away from that linear conception that we move through stages, or that grief happens in a prescribed kind of way. And particularly for folks who are going through infertility treatment, oscillation can happen even faster. I'll sometimes say to people, like, any emotion is a normal grief emotion, or any reaction is a normal grief reaction. And there's also no time prescription. So on the left side of your screen, that loss-oriented coping, you can really think about this as sort of the heavy lifting of the grief experience. This is when we're facing the emotions head on, really in those feelings of sadness or depression or anger, or even denial, really grappling with what or who was lost. And that ongoing grieving or sadness, there might be asking lots of whys or what if type questions. On the other side, we'll also see restoration-oriented coping, which is the ability to integrate that loss into our lives and move forward. And so this might be the presence of really using coping skills even when grief is there, recognizing that there is a need for reprieve from some of that emotional intensity, and maybe even finding respite in new tasks or hobbies, finding a new sense of routine. Before I went to grad school, I used to facilitate bereavement support groups for kids, and we would do an activity we would call grief waves, and we would draw these, waves on a screen or on a page, excuse me, I'm looking at the screen. We would draw waves on a page, and we would have kids put sort of the peaks and valleys of their grief experience. And so when I think about this, this is often what I visualize, those valleys or the low part of the wave, the crying and the sadness and the anger down at the bottom. And then at the top, things like um, laughing about a memory or finding humor in darkness or being able to connect or just feeling close with a person through the grief. And so this is one model of grieving that you can use with your clients. Another tool that you can use is what we call the reproductive story. And this was developed by Janet Jaffe. And this is really the story that we tell ourselves, both explicitly or implicitly, about what we think it's going to be like to be a parent someday. This is a narrative that is lifelong. It includes thoughts and feelings and fantasies and hopes about how parenting and adulthood might look for us, and how we expect things like pregnancy or baby or birth or life to unfold. And regardless of sort of our awareness of this, everybody has a reproductive story. It's a universal phenomenon, and that is true regardless of gender, sexual orientation, culture, religion. It is developmental in nature, meaning it starts when we're young. And when we're young, that story tends to be really influenced by our family of origin. And it's impacted by how we view or see our own family, how we play with other kids, how we show nurturing or caring. And as we get older, we start to think about things like, do we want children or not? And life events that we experience really shift that reproductive story and, again, what we expect to unfold. And then if we partner, or if partnering is part of that reproductive story, then there can also be a period of time where we're really blending reproductive narratives and that concept of what family is with a partner, and kind of negotiating. And so this is a narrative tool that we can use in the context of reproductive trauma or infertility or pregnancy loss, particularly if we notice a disconnect between the story that the client expected to have and the story that they're actually experiencing. And narrative approaches are really common parts to many trauma interventions and trauma processing therapies. And so we can help the client move through the grief process in this way. And so if you were to think about using the reproductive story with our client from before, Lauren, you might first want to check in about your own reproductive story and how your own experiences might translate into patient or client care. What your own relationship was like with your parents or caregivers, your favorite or least favorite memories, and how they might have influenced your own decisions to have children or not. What your larger culture says about parenthood. And if you have a partner, how your story is similar or different from theirs, and what it is like blending your two narratives. You might think to yourself, what are some elements you heard of Lauren's reproductive story? What she expected to unfold about creating her own family? What her family of origin or larger culture say explicitly or implicitly about parenthood and how that might have influenced her own reproductive journey. And how her reproductive story, I don't think I might have mentioned this, but you might think about how her reproductive story is similar to or different from her partner's. And maybe if you're willing, can plop in the chat, what questions might you ask to encourage Lauren's exploration of her reproductive narrative? What are some things that you might want to ask about, or sort of Socratic style questioning that might elicit insight into that discrepancy between what she expected to unfold and what she is actually experiencing? So just to put, if you're typing in the chat, it might take a minute for it to come through for me. And so you might ask things like, oh, there we go. When did she know she wanted to be a parent? Or you might ask, can you tell me a little bit about your journey, about regarding having children or not having children or thinking about becoming a parent? What messages did you receive growing up about pregnancy, parenthood, fertility, or family? How have your reproductive experiences affected your relationship with your partner or family or friends? Okay. Feel free to keep typing those in the chat if there are any others that come up for you. And then real quick, there's so much more that we could go into with this, but oftentimes pain and hardship and suffering do have another side to it. And this is something that's really common across cultures, but is certainly newer in terms of having psychological language or research to describe what that is. And so there's a fair amount of research on a concept called post-traumatic growth, which is positive change experienced as a result of the struggle with a major life crisis or traumatic event. Other terms you might see are things like adversarial growth or transformational coping or stress-related growth. And I think about it sometimes as two sides of the same coin. Interestingly, in the post-traumatic growth research, what was found is that when people are already more resilient, and we think about resiliency more as a personal characteristic or trait, they are actually less likely to experience post-traumatic growth because the experience of post-traumatic growth really involves coming back or enduring psychological struggle and ultimately finding a sense of personal growth. And so if a person is already resilient, they're less likely to experience that because they might not have gone through that same shattering and reconstruction process. And so it's believed that the same processes are actually at play in PTSD and post-traumatic growth. We see this showing up in culture, in literature, in religion, in lots and lots of places. And in the research, what we know is that post-traumatic growth has 5 domains, and there are some measures that assess for post-traumatic growth. And those 5 domains are personal strength, which really speaks to self-reliance, self-efficacy, a stronger sense of self-image, or a more positive view of self. Growth in relating to others, which might include feeling closer or more meaningful or more intimate relationships with others, being able to express themselves more openly or disclose more about their emotions to others. Spiritual changes like greater connection with God or higher power, increased commitment to religious beliefs, or additional religious-based conversations. People who are not traditionally religious might experience a greater awareness or sense of spirituality, or greater engagement with existential life questions, or even openness to the uncertainty about these questions. They might also experience in the domain of new possibilities. And so this could be changes in career or desire to help others or reparative experiences. And then the last would be appreciation of life, which is a sense of being spared in some way, that there could be a new and improved sense of what is important to a person in life, a shift in how they experience or approach their day-to-day life, or even a positive shift in priorities. Dr. Kral is going to speak more about rumination. And so I will just say here that intrusive rumination is what we experience in PTSD, and that is these unsolicited thoughts. Whereas deliberate rumination is really what we're doing when we engage in some of these processes that we are talking about. So it's voluntarily engaging in thinking as a way to make meaning, and even a way to challenge some of the person's assumptive worldviews. And they're really essential to the growth process. Post-traumatic growth has a lot of cultural considerations to it. Does the culture have a language to describe it? What is the role of emotions? How are emotions viewed, or how do we discuss coping with difficult emotions? How adversity is viewed in general. And it involves, as we've been talking about throughout, our beliefs about self, others, and the world. And so when we're facilitating post-traumatic growth, we're not talking about a new therapy, but we're really talking about integrating these into elements of the therapies that already exist. So they're starting early on in assessment, even asking questions about experiences of growth, integrating the possibility of growth experiences into psychoeducation about grief. Helping label ways in which people are managing really challenging experiences through coping skills, integrating it into the trauma narrative, and recreating a sense of safety and building hope for the future. And I want to just clarify, I think it was on a slide somewhere, but growth is not post-traumatic growth is not an expected or necessary process or thing to exist. And so you never want to be forcing this narrative, but sort of in the same way that we're keeping an eye out for the reproductive narrative, we are keeping an eye out for experiences of post-traumatic growth that a person might be having, and putting a name and a label to them. And so the last thing I'll ask you to do before I turn it over to Dr. Kral is think about if there are any ways in which you could imagine facilitating post-traumatic growth with Lauren. What questions might you ask her in any of these domains that might help explore if there has been any growth experienced? And I just listed those domains there to help with brainstorming. And you can put these in the chat again. But you might ask things like, how have these experiences shaped who you are today? Or what strengths have you discovered within yourself having gone through these experiences? Who or what has been most supportive to you? Yeah, thanks for participating in the chat. In what ways has your ability to navigate these experiences surprised or impressed you? I love that. For new possibilities, have you learned anything new about yourself or your goals or things that are important or meaningful to you in life now? Appreciation for life might be things like, how have your priorities changed going through these experiences? Or what aspects of life do you appreciate more deeply now? Or in spiritual change, what role does faith or spirituality play in your healing? Or what spiritual questions has this experience raised for you? And so I will pass the baton to Dr. Crowell, but I really, really appreciated and enjoyed being able to be here with you all today. And thanks so much for your attention and participation, and really happy to continue the discussion on these topics, your email or elsewhere with any of you.
All right, let me get you all back up here. Okay, so I am very excited to be here today and happy to see many familiar names in the chat. I will try and get the chat up. I'm just struggling with that for 1 second. Okay, cool. There we go. So, as a brief intro, I'm Sheila Kroll. I am a co-founder of the Utah Center for Evidence-Based Treatment, and I am also a professor of psychology at the University of Oregon. I was previously at the University of Utah and still have many lovely collaborations there. Today, I will be talking about perinatal rumination and suicidality. My research lab is actually doing a lot of work in this area. We are currently running a clinical trial testing dialectical behavior therapy skills in the perinatal in the prenatal period, and then measuring to see how it affects both the mom and the baby after birth. And so I have a lot of interest and love for this area. So when we're thinking about perinatal rumination, I'm wondering, what are some common words that you and your clients might have used to describe their rumination? What are some synonyms that that you've used, your clients have used for their worries? If you could drop that in the chat, just so that we have some shared vocabulary going forward. Yes, spirals, racing thoughts, stuck in my thoughts, marinating, can't stop my brain, mind can't shut up. Overthinking, I hear overthinking a lot, preoccupied, worried, repetitive thoughts. Yes, overthinking. This is great. Thank you. Yes, so when we're doing rumination focused CBT, which I'll talk about a fair bit, In fact, actually, what I'm going to talk about quite a lot here is treatment. So I'm the third person. You've been here for a long time. If you're missing any stats or definitions, feel free. My email will be provided to get to that, but I'm going to be very treatment focused. Okay. So I see a raised hand. I think it'll be easier if you put your question in the Q&A so that my colleagues can help with that. Okay, so let's define rumination. Rumination is recurrent dwelling on feelings, problems, upsetting events, and negative aspects of the self. And of course, during pregnancy, there are a lot of things to worry about. So health changes, changes to your body, to your weight, to your blood sugars, many things change during the pregnancy and postpartum itself. Finances change, and we talked about how this is a time when people are launching their careers, and that can be a huge challenge. Identity changes. So first-time parents will have a reaction of becoming a parent or becoming a mom. What does that mean? But also, when people have subsequent babies, they have identity changes related to being the parent of a second or a third child. How will that affect their relationship with their other children? And then we have well-established hormonal and more recently established neurobiological changes. So there are changes to cortical thickness. There seems to be a pruning process that is similar to what happens in very early development. And that happens not only for mothers, but for fathers as well. And then changes to relationships. So the couple relationship changes, but also the relationship with other family members and friends change. Other friends who have babies, family members who want to be more involved, perhaps than the parent wants, or less involved than the parent wants. So there's quite a bit to worry about. And of course, there is a significant overlap between rumination and suicidality. So as people are entering this stage of life, if they've had especially prior suicidal thoughts or self-injurious thoughts and behaviors broadly, then those can be triggered all over again. And some people have a new onset of suicidality, suicide ideation, planning that happens during the perinatal stage. So these repetitive, passive, negative, or self-referential thought patterns can sometimes escalate to what if I had never been born, or my baby might be better off without me. And a lot of times there's this comparison with this unachieved standard, right? So I could have been a better parent. I should have been a better parent. That comes up and that affects people's suicide ideation. Both rumination and suicidality serve an avoidance function. So when we're distressed, we want this escape or relief from our pain. And a lot of times suicide ideation or self-injury functions to downregulate distress and to imagine an escape from an unescapable situation. And there's well-established research that rumination associates with both suicide thoughts like ideation and plans and behaviors like attempts or non-suicidal self-injury. This is honestly a more recent development in the literature is seeing this relationship between rumination and suicidality. And so I'll talk a bit more about it as we go along. So rumination follows common patterns. It happens at characteristic times of day. For most people, they'll describe it at times like before bed, when they're bored, when they're on a walk. It's habitual and difficult to notice. So when I teach people about rumination and therapy, I talk about other habits they may have had in their life. So for example, maybe when they were younger, they used to bite their nails, or they still bite their nails. And the thing with biting your nails is that you start biting your nails before you even notice that it's happening. So people will be biting, and then all of a sudden they'll like bite too hard or they'll tear their nail and they'll notice like, ouch. And that happens the same way with rumination. Because rumination happens in our mind, it happens in our own voice, and it's been there usually since mid childhood to early adolescence. People won't even notice that they are having these rumination thoughts until suddenly the thought pops into their mind, "Ugh, I'd be better off dead." And that type of a thought will usually stop a person. Will be like, whoa, what happened to my mood? Why am I in such a bad mood? People don't even notice, but their mood will be getting worse and worse and worse. And then they'll catch like, oh, I'm spiraling, I'm overthinking, I'm worrying. For most people, rumination develops in childhood, and it happens through a combination of some difficult experiences, even normative difficult experiences, and social learning. So when people talk about their rumination, they will tell a developmental story of having someone in their family who is a worrier. So my mom, like I just spoke to someone the other day, and they said, if you looked in the dictionary for warrior, you would see my mom, right? So that learning, when people ruminate, they often ruminate out loud. And so we learn from an early age that that's kind of a way to think or a way to plan or a way to organize thought. And then the most common difficult life experience that people will share with me is some sort of early bullying or social rejection. So they came to school, they were wearing the wrong thing, and people around them teased them. And then they started thinking about, like, oh, what could I do differently, or what should I have done? Because they don't want to experience that again. Another common thing that people will report is some sort of an early loss, like a loss of a grandparent, a pet, and these will get a person sort of thinking and worrying about, will that happen? Could that happen to me? Will that happen to other people I love? And then rumination is easily activated by rumination consistent triggering events. So you have that early experience of some sort of social rejection, and then here you are in your 30s and you say something in a meeting, and before you know it, you're worrying, like, did I say the wrong thing? Have I hurt that person's feelings? Does everyone think I'm dumb? Rumination actually comes from this process of what cows do. So they chew and chew and chew and chew on their grass, and that's part of the digestive process. And when we're describing rumination to others, we'll often map it out like this. So we want people to be able to identify those rumination consistent triggers. What are the things that happen external to their body that they commonly overthink or worry about or spiral about? And then what are their personal warning signs? So warning signs are their internal physiological changes that happen. So their chest gets tight, their stomach clenches, their jaw clenches, they flush, their heart races, they feel a heaviness in their stomach. And then what are the common things that they overthink or worry about, get stuck on, ruminate on, and what are their specific worry thoughts? And then what are the consequences of this? So negative consequences are, mood or anxiety. And the other is avoidance or withdrawal. So a function of rumination is that we feel like we're doing something, but in fact, we're not. We don't do our homework. We don't do our chores. We don't do the thing that we promised our boss we would do. So an avoidance function also maintains the rumination spiral. And when I'm working with clients, I'll often ask all the questions in each of these boxes that I've just shown. And then I'll pull up this model and be like, wow, look, let's just map everything you said onto here. And that can serve like a real normalizing function for the person so that they can understand, yeah, this is common enough that you already had pictures for it. Okay, so what about rumination as a treatment? What is your level of familiarity with rumination-focused CBT? I'm going to give you some answer choices. And this, if you could drop it in the poll, rumination-focused CBT was developed by Ed Watkins. He's British, and so it's really well known in the UK, but way less well known here in the US. Okay, I'm glad to see a few A's and B's in here because I really am excited to tell you a little bit more about this treatment and am glad that I'm introducing something that's perhaps a bit more new. I think I saw a couple C's in the mix. So yes, like I said, this is an intervention that was developed by Ed Watkins in the UK, and it is developed to treat this exact form of rumination that I've been describing, habitual rumination. There are 3 basic stages, and roughly each of these correspond to 4 weeks in the intervention. I've been a therapist in both clinical trials and not in clinical trials in regular practice. And in my experience, when I'm in regular practice, I'll often expand or explore a little more in each of these sections if I have room to not be constrained to like a 12 to 16 week treatment like we are in clinical trials. So it can be done at that pace, and I have done it quickly, and I've also done it with a little more lingering and exploring with the person, their own experience. The thing that's different about rumination-focused CBT from other CBTs, it's very experiential. I shouldn't say that the powerful part is different from other CBTs because all of our interventions have a lot of power behind them. But I think for me, I'd been trained primarily as a dialectical behavior therapist, which has a lot of sort of experiential work. In our clinic, we do a lot of acceptance and commitment therapy and trauma treatments that have a lot of experiential work. And so it was lovely to find a CBT that also was very experiential. And I'll tell you more what I mean about that. And I have a video clip for you as well. So the first stage is the assessment stage. And using guided discovery, the first thing we're going to do is get a general sense of the rumination. So this is to help fill in all of those boxes, but also what is the frequency? Are they ruminating every night? Are they ruminating most nights? Are they ruminating in the middle of the night when they wake up? Some people dream ruminate, so they'll wake up already in a bad mood because they were worrying in their dreams. What are the consequences? So this will help with goal setting in the therapy. What are the contexts where they ruminate? So, I noticed when I did this therapy that I would often ruminate while I was like drying my hair in the morning. And so I realized like I need to put on good music instead of just sitting here like listening to my hair dryer and my thoughts. So those contexts will help us match interventions to the situation where the rumination is occurring. We're going to make sure that it fits the intervention, that the rumination is habitual, and that it's a maintaining problem for the patient and therefore worth targeting. And then we're going to use the client's own words, terms, and examples so that we are like, I'm not going to say rumination a bunch if they're using spiraling or overthinking. And then it's really important to emphasize the habitual nature of rumination because people don't notice that it's happening. It is so common, it's so habitual. And so in this assessment stage, we're really going to try and understand more about what is happening for them. And then this is where we collaboratively arrive at like, okay, rumination is the thing we're going to target and link it to their goals. And then we go into the awareness stage. And this is where I'm going to linger a bit more and show a video in a minute. This is where we're going to help them take what's happening in the back of their mind and bring it fully forward to their conscious awareness. This we do for several sessions using functional analysis. And then we do a functional analysis of the variability. So the video that I'm going to show you is an exploration of the rumination. And then after we do this, where we really bring the rumination to the forefront of their mind, then we'll be like, what is a time when you were, let's just say they tend to ruminate while walking into work. What is a time when you were walking into work and you thought something different, something that wasn't your typical rumination thought? And then the person might track this for a few days and come back and say, so I noticed that on the day when I was in a really good mood, as I was walking into work, instead of thinking, why did I make this career choice? Why am I doing this? Instead, I thought, you've got this. Yeah, you've got this today. And so then we would do a full experiential exploration of the variability in their rumination. And as an example, I'm doing this functional analysis in the video exactly as we do it in the session itself, which is in the present tense. So not like remember back to what happened when you're ruminating, but relive a moment of rumination. And I'll set people up for this quite a bit, where I'll say, if you can't exactly remember what your next thought was or your next feeling was, just go with it as if you were in that moment. Say what's coming up as if you were in that moment. And that's because, again, we really need to bring what's in the back of the mind to the front of the mind so that they can develop awareness of the rumination thoughts that they have. Okay, so let me just set up this video a little bit, and then I'll cue it up for you. So the video is done with one of me playing the therapist and one of our staff members at UCEBT. She is playing for us a client who is already a parent and who's expecting again and who has worries about being a parent and about her experience as a parent. And we're doing the functional analysis of the rumination moment. So she described a common context for her rumination is when she goes on walks after, sort of the kids are done with dinner and winding down or in bed. So that's a common context for her to ruminate. And she had a triggering event of, someone asking whether she really should have another child. So we had explored all of that. And then I'm setting it up to relive the experience of the rumination. So let me share this with you. Oh, one thing to say is that when people are doing this, there's a couple things I want to say, is that they often speak very quietly because we're doing it like very quietly. So I've gone ahead and put the transcript over on the side because Jackie is a little quiet and a little hard to hear at times. You can also, in the ... area of your Zoom, you can turn on closed captions as well, in addition to looking at the transcript over on the side. And then we do this with either eyes closed or a soft gaze. And you'll notice that I'm doing my best not to make eye contact. I'm trying to go through these questions slowly and carefully so that she stays in the experiential of this assessment. And I'm taking notes as we go along. Finally, just for the sake of doing this as a presentation, I did put it in 1.2 speed. I sped it up just slightly because we do these things very slowly so that they sit with the discomfort of their own thoughts. So I'm speeding it up a little bit, and it's still, you'll see, pretty slow. But I want you to know it was even slower. And then finally, even though Jackie and I are playing characters, we're real people. So when I ask for your reflections in the chat, just be thoughtful of our feelings as we share this. Okay. I'm going to start this.
Right. So I will be taking notes as we go along, just to be able to talk back through everything after it's done. So when you're ready, go ahead and close your eyes or soften your gaze. Take a breath in and out. It's evening. It's quiet. You finally have a bit of time to yourself. The kids have gone to bed. You're on a walk outside the path behind your house. It's raining. You can feel the cement of the path beneath your feet. You see the trees with the moss on the trunks. You can smell the rain. The green trees, the mossy trunks, the gray sky, the dark gray path. You can hear the sound of the wind as it's blowing through the trees, the leaves rustling, the bunnies scampering in the underbrush, the rain sounds. You can taste the humidity in the air. You can feel the firm ground of the path beneath your feet as you're walking along, thinking. You can feel the wind on your face and in your clothes. Hear the rustling. As you're walking along, you begin to notice your thoughts. What is the first thought that comes to mind?
Remembering how I was impatient with my kids earlier, not ready to give them the time or space that they needed.
You're remembering this impatience, that you didn't give them the time or space that you think they needed. As you think about that, what emotion is coming up for you?
A little sad, kind of frustrated, overwhelmed.
Let's start with sad. Tell me how sad is feeling in your body.
Really heavy in my chest, my stomach kind of tightens.
And now notice the frustrated sensation. Where are you feeling that in your body?
Upper abdomen, it just feels like really tight and tense.
You notice your heavy feeling in your tense stomach. What is the next thought that's coming into your mind?
Just wish I could be better, more than I am.
I wish I could be better than I am. As you're having that thought, what do you notice as far as your body sensations?
Shoulders are getting heavy and tense.
I wish I could be better than I am. What is the emotion that comes with that?
I think grief. The mom that I'm not.
Tell me that again. Grief.
Grief for the mom that I'm not.
Tell me as you say that thought, as you're thinking it, what is the next thought that follows right after for you?
Just not cut out for motherhood. And it's too late now because I have my kids and they're stuck with me.
I'm not cut out for motherhood. And it's too late now. My kids are stuck with me. What emotion comes with that?
The sadness and kind of a panic.
Tell me about the body sensations that go with panic.
My stomach is really tight. My chest is getting tight too.
So you're having this thought that you're not cut out for this and that it's too late. You're feeling the panic. What are you doing as you're having these thoughts? What's happening?
Walking faster. I'm gonna start running.
Do you notice any facial expressions that you're making?
Running. Those lines between my eyebrows firmly there.
So you're feeling the sensation of panic. You're moving faster. You're frowning. What thought comes next?
I need help. I have to show up for my kids somehow. So I need help to do it the right way.
When you have the thought, I need help to show up for my kids somehow, do any memories come along with that thought?
I think about the difficulties I've had with handling their tantrums or potty training and just wishing that I could have a professional or an expert, kind of like a dog training camp, just take my kids for 6 weeks and fix everything that I can't do for them.
That thought of fixing everything I can't do for my kids. What's the body sensation that comes with that one?
The heaviness in my shoulders and chest.
So as you're continuing to walk along, I want you to move forward in time a little bit to as you're starting to get nearer to the end of the walk. As your thoughts are starting to shift back toward home. What's the thought that comes to mind now?
I've got to kind of put all this behind me and show up for my family again.
And as you have that thought, what emotion is coming along with it?
A little bit of resignation, also some anger, because it feels unfair that untrained people are expected to raise children.
Yeah, so as you have that feeling of anger, you have the thought, how can anyone expect untrained people to raise children?
Exactly.
And then what are you doing? Are you moving closer to your home? What's happening?
Yeah, I'm just trying to get home now that I'm on my way back and just speeding up.
And as you are speeding up and getting closer and closer to home, what's the next thought that comes into your mind?
Some dread of what I'm going to find has happened in my absence. Maybe one of the kids has been up screaming, scared of the dark, something that I wasn't there to respond to right away.
And as you feel that dread, worry thoughts arising about what you'll find when you get home, tell me how your body feels.
My shoulders hurt, get really tense.
Is there a thought that you start to have as you orient toward putting the worries behind and getting back into the moment? Any specific thought that comes to mind?
As I get back into the mode of just being mom, I don't have space anymore to think about these things, and I just kind of get back into the work zone or do what's needed.
Okay. What I'd like you to do is take another few breaths. Visualize this journey, these thoughts and feelings that came up, the path in the trees, the humidity in the air, as if you're back in that moment. And then when you're ready, take another breath, and I'd love to hear what you noticed going through that.
Surprised by how much body tension there is. Like maybe this isn't relaxing a walk at all.
Not this day, I guess.
Yeah. Yeah. I'm wondering if it's really like what I'm putting myself through, if I'm going through my own version of World War III with my kids in the house, and then I go out on a walk and I'm just attacking myself further. I'm not giving myself a break.
I noticed that too. It's very relatable. It's really hard to be a mom. Yeah, not giving yourself a break, lots of tension, living what you tried to take a break from. Anything else that you noticed or that surprised you as you went through it?
Yes, it's surprised at how much anger I have of like, why is this expected to be done in the first place? Or am I breaking up? You're kind of fuzzed out.
Oh, you're good on my side.
Yeah, so I guess there's like a spark of indignation inside of me that's trying to fight back and protect myself.
Yeah. Wow. Tell me more, like a protective instinct. Is that how you describe it?
Yeah, I thought that I was one to just assume that I am the problem, but there's that little hint of anger of, no, maybe the system is hurting things here, and it's not just my fault.
For real. Yeah. How can they expect this of me?
Yeah, why don't we have classes to teach us how to potty train a child or how to respond to their tantrums in a good way? Like we just don't have training.
Yeah.
Okay, so restart the slideshow. So I'd love to hear your reactions, thoughts, questions in the chat. We did both the functional analysis, which usually takes 10, 15 minutes, and then did some of the processing of it afterwards, some of the things that came up for her and that she noticed that surprised her. So yeah, I'd love any. Thanks, Whit. I appreciate that. That's exactly what happened at the end of that video, is that I was like, good job. So I paused it before we got to that part. But I really felt like she leaned into that. And you may have noticed at one point she even kind of choked up a little bit, which is very common. People will have like a tearful reaction when they are doing the functional analysis. I do a lot of prep work in the sessions before, and not trying to scare them, but just letting them know like this will be intense. And then also, one thing I let people know is to not have pets in the room if possible, because our animals can tell when we're experiencing sad emotions. So I can't tell you the number of times that I've forgotten to warn people of this, and like a cat jumps up on the computer or a dog comes and is like, hey, what's happening? So that's how you know if you're doing a telehealth session, that it is kind of an intense experience for people as they're going through it. And you may be wondering, like, why are we torturing people like this? It's not torture really, but it is all that bringing of awareness from the back of one's mind to the forefront, so that people remember. what their voice is saying. Thank you. I appreciate that. It is sort of an interesting thing because that calm voice we use often with mindfulness type activities. And so it does help get people into that moment. And I gathered all of that information before, like tell me about the sights, the sounds, the textures, the smells, any tastes. So that's a lot of why what I did to set the stage for this. And I do think it helps people to kind of go into the more difficult content of their own rumination. A thing that people will often say at the end of it is, I can't believe I say those things to myself. Or I would have never said something like that to someone else. So that awareness is critical for the next stage of the therapy. Okay, feel free to jump in with any other thoughts. But once we have both the functional analysis of the rumination itself and the functional analysis of variability, so a time when some different thoughts may have come to mind. So maybe we do one of a walk where she was like, oh, I had such a great day. Being a parent is hard, but really meaningful, right? There might be different things that she was thinking about, and we would do a functional analysis of that. Then after we have those functional analyses and assessments well done, we move into the change stage. And that's where we develop what we call an if-then plan. So the if-then plan, I'll show on the next slide, is focused on if you ruminate, then what? What do you do? Because we all want some other thing to do. And most people come into therapy and the only skill they have is distraction. So just reading a comment in the chat, that a primary motivation of the intervention is to give full awareness to the impact of their rumination on them and their bodies, kind of like secondary emotions to motivate them intrinsically to want to ruminate less. Yes, versus telling them it's harmful. Yes, yes, yes. So I've certainly been guilty of doing the type of therapy where you accidentally fall into advice. And, when you're looking at someone else's problems from the outside, it can be really easy to be like, well, rumination, is super harmful and it doesn't really help us. And then we just avoid, right? It can be so easy to do that. But we're all more motivated to change when we actually feel it for ourselves, when we recognize it for ourselves. And people will say that at the end of this, like, oh man, this is really having an impact on me. And I know as part of getting trained in this therapy, I had to do my own functional analyses of my own struggles. And it was really incredibly powerful to recognize, like, oh man, I didn't even know I was having some of those thoughts. So yes, great comment. You use this experiential approach in each of the session, and you, in the change stage, you always teach a new skill, practice a skill, and then assign the new skill as homework. And we acknowledge every time that not every skill works for every person. And sometimes when I have more space outside of a clinical trial, I'll find the one that they like the best, and I'll loop back to it a few times. So what does the if-then plan look like? The becoming more aware stage is the if, right? So you know the situation, you know your warning signs, and you know your common behavior patterns and how those lead to rumination, worry, vague, unhelpful thoughts, lots of why questions, why did I pick this career? Why do I always have to, whatever, do all these things that I hate, like blah, 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 whatever things people worry about. And then, of course, when we ruminate, we get more tense. And so that becomes warning signs for more of the rumination to occur and the stress. The then part is we're going to help them to do something different. So when they catch the situation and or the warning signs, they're going to do things that will lead to less stress and break the cycle of rumination. So these things a little bit more clearly are becoming more active. So when we ruminate, we tend to be sitting, we tend to be mulling things over or brooding. And so a lot of times doing things like behavioral activation, going out, dancing, skiing, anything that is like the participate skill in DBT, or an opposite action type of behavior can be really powerful here. Slowing things down. So that's one thing we're teaching in this assessment stage, is how to like, instead of have, I think one of the words that a person used as a synonym for rumination was like rushing thoughts or overthinking. And so getting like to slow it down, be like, okay, I had this thought and then I had this thought, and wait, then I said, you're the worst human in the world. And just slowing it down can be enough for a person to like then come into therapy and be like, I had this, this, and this. And then you know what I said to myself? I'm the worst in the world, like really the world. And I'll be like, I can think of at least, several dozen, 100 million people that are worse than you in this world, right? So then we can kind of play around with it. Um, breaking tasks down. We always tell people to break tasks down, but when we actually have them explore it experientially themselves, that helps them figure out how they would break it down. Opposite action I already mentioned. Relaxation techniques. So we will practice relaxation skills. Concrete thinking. The skill that we do for concrete thinking is a skill called why, how. So rumination questions will be like, why am I the worst parent in the world? Why did I have kids in the first place? I'm not even cut out for this, right? These are rumination thoughts. Whereas how thoughts are like, how can I be a more effective parent today? Or you can ask a what question. What can I do to improve my mood right now in this moment? So you get the vague, unkind thing and you make it specific and concrete. And then what we do for the experiential is I read all of those why questions and I pause between each one so that they just sit with that feeling of what their why question makes them feel like. And then I continue on. I say, okay, pay attention to how you feel and how you're feeling with all those why questions. And now I'm going to ask you these other questions that we generated. I want you to pay attention to how you feel. How does it feel? And I go through like each of the how questions, like how can I be a better mother right now? And then I ask them to reflect on that. They open their eyes, and then I'm like, what did you notice? What happened here? And so the experience that people will report is that when they were asking themselves all the why questions, they felt hopeless, they felt stuck, they felt uncertain what they would do. And when they asked themselves the how questions, they felt like there was some sort of a plan, something they could do, a next step, that they couldn't believe how unkind those why questions were and how helpful the how and what questions were. So that's our concrete thinking skill. Absorption, right? So that's like getting fully absorbed in a task in the moment. We'll practice that in session. Self-compassion will also have them generate. I always tell people I need at least 5 to 7 unkind thoughts that you've had about yourself this week. We're going to get them all written down. And I give them a number 5 to 7 because people will get stuck and I will like get stuck. So I'll just kind of keep encouraging them. Okay, we're trying to get 5 to 7. So give me some more. And then now let's think of 5 to 7 things that are different from these, but that are real thoughts that you would have. So not cheerleading. I don't want you to say to yourself, instead of I'm the worst mother in the world, I'm the world's best mother, right? We don't want those kind of statements. What we want is what you would say to a person who you cared about. If they said, I'm the worst person in the world, what might you say instead? And make it in your own words. So the self-compassion phrases might be something like, I may not always be perfect, but I'm really trying and my kids can tell. So they'll generate a self-compassionate statement. And then we do the same thing. Eyes closed, slow it down. I read the unkind statements, and then we pause. And then I read the kind statements. And then we talk through what was that experience of self-compassion for them. Now, the key about this, one thing I always say at the end when they're like, wow, I felt so much better with those other thoughts, I say, those were your thoughts. I didn't generate those. I didn't come up with those. Those were yours. You already have these thoughts already in your mind. And just like grounding them in the fact that they already, in fact, have a lot of effective thoughts is so much more effective, I've found, than like the traditional CBT of like, oh, let's write down thought challenges. They're like pulling out of their own lived experience the kind thoughts that they have in their brain and their body. And they're so much more powerful for them. And then we also have some assertiveness skills. Okay. So I'm going to transition us for this last little bit into a bit more about suicidality and how we might think about when is rumination-focused CBT a good fit, or one of the other interventions that have come up in this talk, and when might we refer for DBT or do some modifications for DBT. So I'm going to share here just a recent analysis from a grad student in my lab who's now starting her clinical residency. So this is a figure. I'm going to orient you to this figure from her poster. And I'll see if I can attach her poster to your slides so that you have it. This is where in the model we looked at each of these, let me go over here with my cursor, each of these 5 variables and how it associated with 7 months postpartum self-injurious thoughts and behaviors. This line right here down the middle represents where something is or is not significant. And what we could see here is that emotion dysregulation in pregnancy was related to higher self-injurious thoughts and behaviors postpartum. So was their self-reported sleep quality. Mindfulness was related to lower self-injurious thoughts and behaviors postpartum. Rumination was related to higher thoughts and behaviors. And feelings about parenting. Am I a good parent? Am I a good mother? Was also related to higher self-injurious thoughts and behaviors. This is when we put each of these in the model separately, looking at them, they all went in the expected direction. What's interesting is that when we put everything in the model together, we have only 2 that come out as being essentially significant. Emotion dysregulation prenatally was related to 7 months self-injurious thoughts and behaviors, and rumination prenatally was as well. This is actually a sample of Utah moms, so this is relevant to those of you who are living in the Utah area. So rumination clearly is an important part of understanding who's going to be at risk for self-injurious thoughts and behaviors broadly postpartum. So when it comes to treating self-injurious thoughts and behaviors, obviously, many of you know that dialectical behavior therapy is a gold standard treatment for that, and it is designed to reduce emotion dysregulation. It also has a lot of skills that are very effective for rumination. As you noticed in RFCBT, we're teaching things like opposite action, which is a skill that is used in dialectical behavior therapy as well. So there are full program DBT has 4 modes of treatment: individual therapy, skills group, phone coaching, and a consultation team that's supporting the therapist. So it's really important to know that as we talk about modifications, that you want to be informing your client that some people can respond to lower doses of DBT, but some people don't. And telling them that is very important so that they can choose if they want to do something like a full program DBT experience. If they just do part of DBT and it doesn't work and they didn't know that they weren't getting the whole thing, it can be a little bit like antibiotic resistance. People will develop a DBT resistance, like, oh, I tried that and it didn't work. And then it's like, well, did you do the whole full, like 4 treatment modes, and a lot of times they have not. So that informed consent is really helpful and important. So we can talk about the full model in commitment. So commitment for full program DBT is about 4 sessions. And in those commitment sessions, we're listening for things like their target behaviors, like any life-threatening or self-injurious behaviors, any therapy interfering behaviors, right? Do they quit? Do they get angry with therapists? Do they text bomb therapists? Things that may have happened in the past that could get in the way, or that you as a therapist might do that could get in the way. Any skills deficits or quality of life interfering behaviors, sleep problems, eating problems, having a pregnancy-related health concern that is likely to come up and interfere with therapy, and then any risk for dropout. And obviously in pregnancy, and we'll talk more about this in just a second, you have to think about if it's pregnancy or postpartum, how is the birth of the child or other factors going to affect treatment. Childcare issues, for example. And then we go through the biosocial theory, explaining to them a bit of what are the factors that may have contributed to them being in this level of distress. Go over the importance of skills and some of the quote unquote rules of DBT, the guidelines really, and it's a trust building phase. And our goal from these 4 sessions before we start full program DBT is to make sure that the client feels heard, understood, and that we can say, I have something here for you. And, if you've seen that DBT skills book, it's thick. There's a lot in there. I'm like, you know what? One or more of these skills might actually be helpful for you. And I want to really orient people to their goals. So like if they've said, my goal is to be a more present and grounded mother. I want to be there for my kids. I want to be calm. I don't want to yell when I'm upset, when I'm in crisis. I want a more effective relationship with my in-laws and with my partner. And I want to feel in control of my emotions instead of my emotions running away with me. So just like in rumination focused CBT, where we put things in the client's own language, in DBT, we're going to link all of these goals to the skills that are taught in DBT: mindfulness, distress tolerance, interpersonal effectiveness, and emotion regulation. So what do we know about whether full program DBT works for perinatal populations? Yes, there's a small body of literature that is looking specifically at this. And like I said earlier, we are doing a clinical trial of a skills-only focused component, again, with informed consent, that it's not the full program during pregnancy. So if you're starting in pregnancy, and you're planning to do the full program, you could introduce the full program and plan for your pause, right? At what point postpartum would be the right time to come back? For most people, it's somewhere around 6 to 8 weeks that they feel ready to come back for therapy if they have support, someone who can have the child. And many of the DBT skills groups that are going on right now, there's a research study of full program DBT that is happening with parents of toddlers. And they just talk a lot about who can be in the room, babies, kids, what are the pros and cons of that, and make sure that as much as possible, the mom's able to fully devote herself to the work. You can also modify and adapt like we are, teach specific skills that are focused on parenthood. So that is another thing that you can do. And then many people in full DBT are already parents. So that's this Zalewski citation. Maureen Zalewski has an article just about, hey, if you're doing any clinical work whatsoever, you should check if your adult clients are also parents and think about how to bring parenthood into your work more broadly. And then for mothers, there is, of course, the unique issue of motherhood guilt and shame. I have only one more slide, just so you know, in our last minute, and I will stick around for questions. one major theme to assess in this work is reasons for living versus reasons for not dying. So many people will say, oh, I couldn't abandon my children. And I'm like, that's good. That's a reason for not dying. Also, why, like, what's a reason for living, right? So people will say, I want to be there for my kid's graduation. So getting that distinction can be really helpful. Okay, final slide. Don't worry about referring for full program DBT. A DBT therapist will adapt and adjust flexibly as needed. And if you can't refer for full DBT, or even if you're able, a crisis response plan can really help for people who are experiencing suicidality during this stage. Okay, thank you all. I will stick around and look at the Q&A for anyone who has it. And what a journey we've been on together. Thanks so much.